So, hi, I'm Laura. Most of you know me. I'm one of the senior CNSs, currently working on the ward as well as the manager. But I just wanted to do a presentation today about malignant melanoma because there's been quite a lot of research into melanoma that's been quite exciting. So, yeah, I just thought I'd go through it with you. Some lovely pictures of moles on the front, all of which are melanomas. We're going to have a little look at different types of melanoma, the incidence and treatments, and the emergence of immunotherapy, targeted therapy. And then we're going to have a little touch upon the seminal research that was done, why it's important, and what this means for us in practice. Became quite interesting to me because 10 years ago, only 1 in 20 patients with advanced melanoma would survive, and with many just living for 6 to 9 months. So chemotherapy offered response rates of about 20 to 30%, but there was no clear survival benefit. And I suppose I've looked back over my career and sorry, someone, can you just put yourselves on mute, please? I can just hear some background noise going on. Thank you. And it's just interesting that I don't know many melanoma patients as I used to. And in the community team, we recently had a patient that actually ended up on the IPU that I saw around the time just before I went on maternity leave, so nearly 4 years ago, and thought that she had the possibility she might be dying because she got diagnosed with brain mets, but actually 4 years later she actually did die on the IPU with her brain mets. So it kind of got, gosh, it has come a long way from the patients that I used to look after. What is melanoma? So melanoma is a type of skin cancer, and it starts in the cells of the skin, melanocytes, and they're basically the things that the cells that give colour. So sometimes it can start off and look like a mole, or it can also be normal looking skin as well. So we know from extensive research that UV radiation can build up and damage the DNA in these cells, and they start to grow and divide more quickly than they usually do, and that's when it can develop into a melanoma. So there's types of melanoma. So there's 4 types in total. There's some other kind of obscure types, but the main types that we see, well, which is a superficial spreading melanoma. So this is the most common, and it's found on the arms, legs, chest and back. So usually the parts of us that have been exposed to more sun. The melanoma cell usually grows slowly at first and spreads out across the surface of the look like the picture. There are some pictures, so if you are squeamish, there's nothing to pictures, but usually it will start off looking relatively like it looks like a mole kind of in the middle, and then it grows the edge around. It looks much more unusual, much more irregular. And there's a melanoma, so the second most common type, can grow more quickly. It's more growing, so you can see there in the middle where it's been drawn around, it's quite red. It does look like a nodule, hence where the name comes from. And they start off looking quite red rather than black, and most common on the chest, back, head or neck. Lentingo maligna melanoma. So these are much more common in people that have had lots of sun exposure, and to those areas such as tips of the ears, can look like a large freckle, and they can some Hutchinson's freckle. They are, so this can be quite precancerous condition, and it only is in the so it spreads into the deeper layers of the skin if it's and it's no longer then classed as and then that's when it can transform into a melanoma. So that is a tip of those that can't kind of work it out. It's a bit of a terrible picture, actually. Okay. And this is an acral lentiginous melanoma. So quite rare, usually found on the palms of the hands, the soles of the feet, or under the fingernails or the toenail. Much more common in people with a darker skin tone, and it's not thought by sun exposure. And it's the melanoma that actually killed Bob Marley at the age of 30. Little fact there. So just to revisit, we spot signs of the melanoma. We use the A, B, C, D, E to help us distinguish. And you can see the differences between the two pictures looking at the age of a lesion. Usually one half of the other half. So you can see the one on the left is nice and circular, and the one on the right are regular. And as we go through the border, so things, the melanoma ragged or blurred. The colour could be uneven, and sometimes they are, you can see the melanoma there has kind of some black pigmentation in it with some surrounding as well. So the diameter, so less than 0.25 inches or greater than, melanomas are usually bigger. And evolving, so how's it changing shape and colour? And colleagues that are just about to do their health assessment, this might just be quite handy for you. So the stages of skin cancer. So stage 0 is no spread or surrounding areas, and it can also be called a carcinoma in situ. Stage 1, bigger, across, or so 2 centimeters across or smaller. And then stage 2, it's getting a little bit bigger, but no larger than 4 centimeters. And then when I like this, the ambiguity comes between stage 3 and stage 4. How you define them gets a little bit more complicated, but stage 3 is larger than 4 centimeters. It's grown into nearby bones and space around a nerve. It's grown below the subcutaneous tissue, and it's single lymph node, or on the same side of the body as the cancer. And then stage 4, it's kind of all of the above, but it's then spread into other organs as well. And usually for stage 0, 1, and 2, they'll have some surgery. Stage 3 and 4, they have to look for other interventions. So the incidence of melanoma, so around 15,000 people are diagnosed with melanoma here in the UK. So the survival rate for people with melanoma has doubled in the last 40 years. So the 10-year survival rate is 87%, which is really quite good now. The incidence of malignant melanoma in Britain is faster than any other common cancer. So it's increased almost by half, which is incredible. It's the 5th most common cancer, and it's nearly a 50-50 split. So 1% of cancers are males and 49% are females. And obviously quite common with age due to the more sun exposure you had off. So the treatment, so first line treatment, hopefully surgical excision. So you would get your best result being able to take out that melanoma as quickly as possible. Spread to other places in the body, they can consider radiotherapy, chemotherapy, but we've discussed, and immunotherapy and targeted therapies as well. The ones that I really want to concentrate on for this part of the presentation, but it has been just epic for melanoma, and then being quite of cancers as well. So I'm just going to go through in hopefully simple-ish terms what immunotherapy is. Like, I think before I fully understand that there was this class of drugs that were doing different things. So we have targeted immunotherapies, and they do different things within them, and what actually are they doing? So immunotherapy uses the patient's own immune system to recognize and kill the cancer cells. 2 different types of immunotherapy which are becoming really important. One of those are inhibitors. So I've put the names up there. So ipilimumab, which you probably and patients might also call them by their brand name, which I've put in capitals as well, or Pembro or Nevo as well. So I will call them Ipi, Pembro, and Nevo. I can't say them. I can't say the whole name. I've tried. And virus therapies. So virus therapies are kind of emerging for, and they're doing lots more research into them. So basically, the virus is designed to infect cancer, and then that helps your body's own immune system to find and destroy that area of melanoma. So this is so where we're using checkpoint inhibitors all over the country, at all different hospitals. Virus therapy tends to be in your big cancer centres. Only be used if the melanoma hasn't spread to other areas. So you can see my little there. So the tumour cell binds to the T cell to deactivate them. Sorry, I'm just going to move my little window. And then immunotherapy drugs could even block tumour activating that cell. So it's a kind of two ways of how it works. So it's binding and deactivating those tumour cells, and then it's kind of blocking them activating. So hopefully you have a bit of longevity of treatment, which I'll go on to later on. So possible side effects, which I think is really important. So definitely in my palliative care experience, we're seeing many more people having immunotherapy now, and their side effects are quite challenging to manage, and they really are trying to find a way of putting it. They are different between person to person, and they can really limit how much a patient can tolerate, I think is fair to say. How often and how severe the side effects vary. Early reporting can help. I think the oncology teams are really encouraging patients to keep and monitor how those side effects are. Sorry, can put yourselves on mute, please? Thank you. So there are some of the side effects that we see. So I think it's fair to say that immunotherapy isn't without a side effect burden. To say that it's gentler or works in a different way to chemotherapy, I think it's true to say it works in a different way, but I think it would be fair to say that the side effect burden is pretty similar and absolutely can be quite limiting. I'm not entirely sure that the patients are upfront with the symptoms that they're having, and sometimes they may not know as well. So sometimes things like being constipated or being sick might be put down to the cancer that they've got, or things like their hair's falling out, or they've got kind of generalized muscle aches. But the research that's come through about side effects, usually the quicker that we get on top of them, the better. But it's just being able to do that. So they grade the side effects. So you might see written in notes a grade 1 to a grade 4. So I think that's quite interesting to note, that the oncology teams are always looking at these side effects and figuring out if they need some stronger immunosuppressive therapy or steroids or stopping treatment at all. And there are obviously a bunch of patients that don't tolerate the side effects at all. So targeted therapy. So targeted therapy targets something in or around the cancer cell that's helping it grow and survive. So I kind of think of it like a lock and a key. So if the patient has a mutation, so they're tested for a mutation in the gene, the one that we're testing for at the moment is BRAF. So BRAF has been shown to be really, really useful for melanoma, but they have to have the mutation. So if you have a key that doesn't fit the lock, then you're not going to open the door. So they have to have this BRAF mutation in their gene. So targeted therapies use a combination to treat melanoma. So they're all the sorafenib, trametinib, and all of the rest that I can't pronounce. So the drugs work by blocking the signals that tell the cancer in the cells, that tell cells in the body to develop and divide. So by blocking those signals, those drugs stop cancer cells from developing and dividing. So you can see on the picture on the right, sorry, the normal cell and the normal signal source, and how this BRAF mutation can cause out of control signals, which increases the cancer cell growth. So usually what we're seeing is there's patients with BRAF mutation in their genes usually have a more aggressive form of melanoma. So some of the side effects for targeted therapies, and mainly what we're seeing at the moment is diarrhea and liver problems. So they can be quite significant, and they can have problems with their clotting or wound healing, high blood pressure, fatigue, mouth sores, nail changes, loss of hair color and skin problems. So side effects depend on the growth factor for the treatment that it's targeting on. So some work on the epidermal growth factor, so they'll cause changes in the nails and the hair. Some work on liver and some work on cardiac as well. So depends on what growth factor they're targeting as to what side effect profile they might get from it. So then I started to look at the timeline for melanoma and the treatment of it. So you can see kind of back in the 70s and the late 90s that we just had dacarbazine, which is an interleukin-2 chemotherapy drug. So we know that 20 to 30% success rate for these patients, so pretty poor. And then in 2010, 2011, there was a little bit of a surgence for investigating different treatments for melanoma because the outcomes were so bad. So they came across ipilimumab. So ipilimumab is our immunotherapy, and then underneath the nib is our targeted therapy. So as you can see, as we've gone on, lots of different ways of treating melanoma have been kind of thrown into the pot. And some of these we're going to concentrate on. So definitely 2010, 2011, and then on to 2015 as well, when we added in this Pembro-Nivo mix. And then you can see on the orange below are subsequent pieces of research. So the DABRA and the trametinib have been quite, the outcomes for melanoma have been quite dramatically increased by this combination. And then going on for 2016 as well. So Nivo and Ipi is now the treatments together, combined regime for melanoma. So I just think that's quite, for me, it's just totally fascinating how in such a short period of time, things have come such a long way, when in 2010, people were dying within 6 to 9 months of this disease. So in 2010, there was a paper written by a chap called Stephen Hoddy, and he is basically the pioneer for research with immunotherapy for melanoma. So he did some research with improved survival with IPI in patients with metastatic melanoma, not really knowing how it was going to go. But the undertone to the paper was a little bit like, well, we've got nothing to lose because these patients are dying. And we need to try and see if we can make a difference, really. So this was it was a huge turning point in melanoma, and it was quickly followed up by a phase 3 randomized double-blind multi-center trial with looking at monotherapy and then the vaccines as well. So with these trials in 2010, 2011, melanoma therapy reached a milestone with the introduction of 2 new agents, so the IPI and the VEM, which demonstrated a survival benefit in randomized phase 3 clinical trials, which in research speak is pretty good. So this was the first tumour group to use immunotherapy, and that's just 14 years ago. And the trial also researched stage 3 and stage 4 patients, which is a group that were rarely being looked into. So not only have they found something that's quite successfully treating melanoma, but they're also breaking boundaries with looking into alternative drug therapies and looking into a cohort of patients that aren't being researched. So then there came the Checkmate study. So Checkmate 067. So this was a trial done in 2015, which set the current international standards for care for first-line metastatic melanoma. So it was a 3-arm trial with 3,000 patients, so quite a good number of patients. And it was a really pivotal trial aimed at comparing the combination of Ipi-Nivo with Ipi or Nivo. So looking, do we use them together or do we use them separately as drugs? So the long-term outcomes reported at 6.5-year overall survival, and melanoma-specific survival at 49% or 56% for the Ipi-Nivo combination. And there you can see the numbers for Nivo on its own and then Ipi on its own. So it's been revisited, and they've done a 10-year outcome, which I think they didn't quite believe they were ever going to write a study that had 10-year outcome. But the final trial showed a continued and ongoing survival benefit with this Ipi-Nivo combination in patients with advanced melanoma. And importantly, and I think probably one of the main outcomes of the trial is that the survival curve has something called a stable tail, which is plateaued over time. So that kind of supports this view that, presuming that patients on the tail are in fact cured of disease, there could be this long-term, an increase in the proportion of long-term survivors even further when we look at more patients. So that's been absolutely huge outcome of looking back at the data over these 10 years, is that actually not only have patients continued to live, but they are continuing to live past this 10-year outcome, which is pretty incredible. When we're still looking back 10 years when people were dying really quickly from it. So what? So some people are responding in the first instance, and then there's this enduring response. So this has been quite an important outcome of the study, is that immune memory from T cells that just keeps working after a treatment has continued. So this could show that there's a group of patients that respond forever, but the immune system needs time to respond. So when we spoke on our previous slides about, let me see if I can find it again here, about these, I mean, how these immunotherapy drugs work. So, and on the right-hand side with the picture, so the drugs can block tumor cells from deactivating the T cells. So in theory, that could last forever, and you could have a prolonged response, which does blow my mind slightly. So what does this mean for us in practice? And one of the things they mention within the study is this notion of pseudo progression. So not necessarily seen in other tumour groups, but I would argue maybe lung. Like, is it progression? Is it a lag? Or is it something else? So this is basically saying when they're scanned after however many treatments for their immunotherapy, I think the current NICE guidelines is that they give 4, so 12 weekly course. And their scans, they don't necessarily, they feel well, look well, but they've got disease progression. But is that because we haven't given the immune system enough time to respond? And then well, not necessarily us as palliative care professionals, but how do the oncologist discuss that to the patients, and how do we describe that, and how long do you give it, I think is the ongoing challenge and battle. All different cancer centres have different, I would say, opinions on this. It's quite clear within the literature. So first scans might not show a response, and it's really reframed, I think, how quickly oncologists treat patients. So bearing in mind it can take a while for this immune response to occur. How quickly then do we need patients to be treated? So there can be an increase in side effects because there's a new combination of therapies. There'll be more patients living with. And I suppose my question to the audience is, do we think that this is going to lead to later referrals to palliative care? And when do they refer? Is it appropriate for them to refer? Acknowledging that you could have a patient that could be cured by this, but could be ravaged by some symptoms as well. So I'm going to open that up to the audience. Someone's brave enough. Oh, go on. No, none of my CNS colleagues have any.
Oh, it's Sarah here. Hi.
Oh, Sarah.
I just had a comment. I remember on the ward several years ago now, and we had a chat with head and neck cancer, who was having immune therapy, and every time he had a dose, he would get acute severe stridor. And yet the oncologists were like, well, you know, he's for palliative care. We're not bringing him back in. But I'm like, but you're treating him and causing the stridor, and you're carrying on giving immune therapy. But when he's in acute stridor and maybe going to die from it one time, we can't send him back to you to manage that. And I couldn't understand their rationale. Yeah, I mean, either they were going to keep giving it or not. And if they were going to keep giving it, surely it was a side effect they had to manage, not just go, well, if he ends up killing him with stridor in the interim, he's palliative. It felt really weird.
Yeah.
So it's really hard to know quite where you are with what you do about things when someone's in the middle of immune therapy. And I'm not sure the oncologists know either, which is probably why I got what seems like a really silly response to my, what do you
I
want us to
absolutely
do?
agree. I think it's become, thank you, Sarah. I think it's become so ambiguous about how we manage patients that are pretty poorly with immunotherapy, but they stay up. From my recent experience of looking after someone with metastatic melanoma, it was a bit like, well, you know, that's just what happens. Like, that's just the terrible liver derangement that you're just going to have to entail, really. And it was just quite interesting looking back at her from the time that we hadn't seen her for those 4 years. She'd just been in and out with quite significant toxicities, but nothing I'd ever seen during when I was giving chemotherapy. So it feels like the playing field's completely changing, really. And how do we manage those patients? How do we? Because I think definitely for my CNS colleagues, we're quite open and honest about discussions, but where do we pitch those discussions for patients like this can be really challenging, and not overstepping the mark or, you know, being shot down by an oncologist. So what next? So further developments coming out for ocular melanoma. So ocular melanoma, the survival is pretty appalling, to be honest. Treatment is quite horrendous, and they've not seen a great increase in survival like they have for skin lesions. So there is some emerging treatment for that done by that Stephen Hoddy. He's bringing some out later in the year, apparently. There's going to be further work to come out of the checkpoint 067 trial. Lots of information for oncologists by the looks of things, lots of trying to standardize practice and best combinations of drugs to use. And they're going to look more into growth factors and the BRAF, and see if there's anything else they can isolate to be able to target. And it really has, right, regardless of how, you know, I feel as palliative care nurse about immunotherapy, it really has had some exciting development and set a precedent for how we use immunotherapy for other cancers. And specifically, there is a link between melanomas and the treatment and that emerging treatment, but also for renal and lung. So renal and lung patients, outcomes also not great. And immunotherapy really has been emerging for those as well. So that's been really interesting. So if you're really interested in immunotherapy, there is a great podcast called the Immunobuddies podcast. So they talk all about, so the two oncologists that talk all about immunotherapy for different cancers. They have patients on there asking about side effects. So actually I had a little listen before I wrote this, and it was quite informative about what patients are living with, how they're managing it. Some of it was completely over my head, but other bits of it was really interesting. So that's me done. I'm a bit earlier than wanted to be, but any questions at all? No, that's good. Bored everyone to tears.
I'm not sure it's a question so much, but because immunotherapy is relatively new, I don't think we know enough about the long-term implications that it's going to have for our patients, and whether we're going to find that we end up looking after a cohort where the oncologists have said, actually, our work here is done. We have treated the cancer and the cancer is gone. But 20 years down the line, someone has got something grim, as you were saying, with the kind of side effect burden. Because there was a gent a while back who was completely cured of his melanoma but had gone blind.
Yeah.
Under the care of the Marsden, who we looked after. And I think that's going to be a bit of a grey area for all of us as to who is responsible for this cohort of people with very unusual and novel kind of issues for us to deal with.
Yeah, I completely agree. I think it's going to get quite complex. And especially if the research coming out is that actually we're able to we're able to do something with the T cells and give them a memory so that we don't have to keep giving them treatment. But how do you turn off the treatment? And I think that's one of the things that they mentioned within the podcast, is that how do you stop something if it's doing harm?
Mm-hmm.
And at the moment, we don't know.
And if it is going to continue doing harm, is it an appropriate thing ethically for us to give?
Yeah. Yeah.
Have you heard about, I think it might be the Stephen Hoddy guy. There's a guy in Australia who was very key in the immunotherapy research, who's developed a GBM, and they're now using.
Yeah.
Is it him?
No, he's American, Mr. Hoddy. Sir
So they're
Hoddy, whatever he is.
using the immunotherapy specifically to target a
Yeah.
glioblastoma, and he's doing remarkably well.
Yeah.
So for another kind of really difficult to treat cancer group, we might have finally something that works, but with a lot of caveats.
Yeah, absolutely.
It's a really interesting area.
Yeah, super interesting. Kind of could have gone down a bit of a rabbit hole, really, but
No, really good talk. Thank you.
No, amazing. Well, if there's nothing from anybody else, any comments, or then we can leave it there. Lovely. Thank you very much.
Thank you, Laura.
Thank you.
Thank you.